I'm Teresa Comstock. I'm the Executive Director for the California Association of Local Behavioral Health Boards and Commissions. Thank you for joining us today. We will have a presentation from Elizabeth O. Segarra with the California Alliance for Child and Family Services, and she's also a member of the California Behavioral Health Planning Council. Um, every year, the boards and commissions, the 59 boards and commissions, are asked to complete a survey from the California Behavioral Health Planning Council. And this year, their focus will be on foster youth. So I really appreciate that Elizabeth reached out asking to provide this information to all of you. And I know there's a lot of staff on the call as well. So she's aware, and there's a lot of interest in this topic. We had, I think, about 120 people register. So we will have a recording of this afterwards that you can share. So I'd like to introduce Elizabeth Oseguera. She is, again, with the California Alliance for Child and Family Services, and also a member of the California Behavioral Health Planning Council. And she's also a court-appointed special advocate, so she works directly with youth that way. And so I'll go ahead and let you get started.
Thank you so much, Teresa, and thank you all for joining and allowing me to present information around high fidelity wrap, the tiered rate structure, and wraparound immediate needs, all of which help shape how foster children and youth access behavioral health services under the new construct of high fidelity wrap and wraparound. So next slide. So really quickly, just wanted to give folks the agenda that we'll be going through. We'll overview with the California Alliances and the work we do. Then we'll talk about high fidelity wrap and how it relates to you all as behavioral health board and commission members. Then we'll dive into an overview of high fidelity wrap and its connection to wraparound immediate needs. Then updates on implementation, advocacy efforts, and then Q&A. So there are going to be pieces that I'm just going to fly by because I'm trying to get through the slide deck and share as much information as possible with y'all. But feel free to slow me down if needed. So the Alliance represents over 160 nationally accredited nonprofit community-based organizations, really dedicated to serving children, youth, and families. Our members work and offer a multitude of services, including behavioral health care, foster care, juvenile justice, education, prevention services, and work throughout the whole state, so all 58 counties. Our primary objective is to ensure California's children and youth have what they need in order to be successful in life. So if they need to have access to certain services, including housing, being able to facilitate that, making sure that we are advocating to the administration and the legislature on their behalf on what those needs are, and push for policy reform to build stronger networks that meet their needs. Next slide. So some key member benefits that we offer is advocacy and representation, as I mentioned. Making sure that we are giving access to information. So if they need to know what is high fidelity wrap, we help answer those questions, provide them resource libraries and things of that nature. We also offer training and professional development through our Catalyst team, and then networking and collaboration. So working to meet their legislative representatives, congressional members, and things of that nature, so that together we could create the reforms our system needs to help support families, youth, and children. So next slide, example of our members. Here's a few of them that you may have heard of. So I picked some larger names. So Casa Pacifica, St. Anne's, Mary's Path, that's really residential care for those who are pregnant and parenting young moms. And then other spaces where residential care is given. Next slide. So now going into the meat of things. So understanding how high fidelity wraparound, the tiered rate structure, and wraparound immediate needs matter to the work of behavioral health boards and commissions. So you'll start seeing me use some acronyms here. Stop me or put in the chat if you need me to define anything. But essentially, we want to talk about the intersections between high fidelity wraparound that is going to be living in the behavioral health space, and then the tiered rate structure that includes wraparound immediate needs funding that is being used to then leverage the federal match for high fidelity wraparound. So there's a lot of intricacies that I'm going to try to dispel and help explain to y'all. But again, if there's any questions, feel free to put them in the chat or raise your hand and I'm happy to take them throughout the presentation. Next slide. So perfect. Behavioral health boards and commission responsibilities. Because Teresa told me that it's not just behavioral health board commissioners on this call, that there's other county staff on the call as well. So I wanted to provide an overview of behavioral health boards and commissions responsibilities. So in California, these boards and commissions are mandated by state law to evaluate and advise on local mental health and substance use disorder services. They operate as advisory in the advisory capacity and really are a great bridge between community, county leadership, and service providers. So essentially making sure to raise voices from the community to then help influence what the county plan looks like, and then help to ensure, as you're reviewing county contracts, that the provider network is intact and available to serve these families and communities. So according to California statute, Welfare and Institutions Code 5604, you must review and evaluate the community's public behavioral health needs, services, facilities, and special problems. Advise local leadership. This is where that county advisement comes into play. Review county contracts, including FSB programs. Review and approve procedures to ensure citizen and professional involvement throughout the planning process, so making sure that community voice is actually heard. Provide annual reports and review and comment regarding performance outcome data. Next slide. So why should you all care about high fidelity wrap and win? So foster youth have some of the highest behavioral health needs in California. Whenever you come into the child welfare system, it's very likely that you have suffered some kind of trauma. So it already puts you on that heightened space on needing those behavioral health services, triage, and therapy supports. High fidelity wraparound is designed to improve outcomes. So it's supposed to create an individualized family and youth-driven care plan that coordinates services across child welfare and behavioral health, including education and just generally, like if a youth has a strong mentor from a previous program, maybe a great therapist that they loved, making sure that those connections remain intact for that youth. So that's high fidelity wrap. So how it kind of ties into the tiered rate structure and child welfare services is that under the TRS, so that's the tiered rate structure, children and youth with higher levels of need are expected not only to receive high fidelity wraparound, but also what we're now calling the wraparound immediate needs program access. So there's, and you'll see this in future slides, but there's rates right now under the tiered rate structure where there's immediate needs funding that would be offered as the federal match for counties to then implement high fidelity wrap. But in order for counties to access those additional dollars for that Medi-Cal match, they must also provide wraparound immediate needs services. So it's taking wraparound that lives in behavioral health and adding those components into child welfare, therefore doing a tie between both of them. Behavioral health boards and commissions have a very important advisory role. You all are reviewing high fidelity wrap within FSB contracts already. So in the 3-party contracts that were developed and due this past March, counties had to put in there how their FSP programs would essentially tie to high fidelity wraparound. And making sure that we're moving the system into this high fidelity wraparound concept of giving the child and the families whatever they need when they need it, and making sure that there's funding available to meet those needs. Next slide. So kind of diving more into understanding the tie between high fidelity wrap and win, which is I think one slide over. And so wraparound immediate needs, as I mentioned, white care one, there you go, that one, slide 9. So wraparound immediate needs is the child welfare funding component within the newly proposed tiered rate structure that complements high fidelity wraparound. That's where the tie happens. When providers flexible funding, so there's these immediate needs dollars, we're hoping as providers to have it be more of a flex dollar and a little bit less of a Medi-Cal match. But we understand that that medical match will be very crucial for counties in order to implement high fidelity wraparound. So we're trying to work with our county partners to understand what that balance needs to look like. The County Behavioral Health Directors Association, CBHDA, they've released comment letters where they say at least 50% of immediate needs dollars should be flexible dollars and not tied to the medical match. Something that we appreciate and agree with, and would actually say let's extend it to maybe 75% of non-Medi-Cal match to ensure that there is that flexible dollar to meet whatever needs that family and youth have and not have to tie it to Medi-Cal. If it doesn't fall squarely within Medi-Cal billing. Behavioral health boards and commissions will be serving as a bridge between behavioral health and child welfare partners, because as you're reviewing contracts, specifically maybe around high fidelity wrap, RFPs that are going to be coming out and for some counties have already been released, making sure that the behavioral health side of the house is working in partnership with child's welfare. The importance of that is one, making sure that the county can access the wraparound immediate needs funding, and two, making sure that there's providers in child welfare today that then can provide services under behavioral health tomorrow. Meaning high fidelity wraparound RFPs, we're hoping to see less around having to have wraparound experience in the last 3 to 5 years, have that be not a requirement so that child welfare serving organizations can then be included in the high fidelity wrap network of providers. And when the county is ready to implement WIN, maybe as soon as July of next year, then you all would already have a provider network that's representative of both behavioral health and child welfare entities. And then as California transforms both the child welfare financing and service delivery systems through the tiered rate structure, high fidelity wrap, and the wraparound immediate needs program, behavioral health boards and commissions have a very unique opportunity to ensure that these reforms translate into better behavioral health outcomes, stronger cross-system collaboration, which is key here, and then just overall improved outcomes for children, youth, and families involved in the foster care system. Next slide. I also wanted to mention the California Behavioral Health Planning Council data notebook. Teresa kind of mentioned it in her introductory remarks, but the California Behavioral Health Planning Council works in tandem with the behavioral health boards and commissions to put out a survey, if you will, to report findings and recommendations on the performance and programs annually with the legislature, BHSA, and you all, the local behavioral health boards and commissions. So the idea here, there is a WIC code 5604.2 A7, if you want to get really in particular, you can look it up, that talks about the Behavioral Health Planning Council creating a data notebook to then provide annual updates to the legislature, DHCS, with the contributions of all of you through a survey responses to really share how behavioral health access is being communicated and actually attained at the community level. And what we started to do with this data notebook is to really focus it on very niche populations. So as Teresa mentioned, this year, the data notebook is focused on behavioral health access for children and youth in foster care. And we're using the opportunity of exploring access to behavioral health care for foster youth to also explore how high fidelity wrap and the tiered rate structure, which includes the wraparound and median needs program, will hopefully improve access to coordination of this care. So I hope the lines and connections are starting to be a little bit more clearer. I just noticed my camera went off. Oh, right. So now diving a little bit more into high fidelity. So if we go on to the next slide, slide 11. So going and diving a little bit into high fidelity wraparound. So again, what is high fidelity wraparound? It is new essentially to California because not wraparound. Wraparound has existed in all counties, and each county defines wraparound differently and applies it differently. But what's new is the high fidelity piece. It's attaching fidelity to wraparound outcomes and how wraparound functions, and then creating a streamlined process on how high fidelity wrap looks like in California. So not county by county, but have a structure where there's alignment throughout all counties because they're, attaching it to high fidelity wraparound, and how they're reporting on outcomes and having to do a bunch of trainings that again streamlines what wraparound looks like in California. So it's an evidence-based, team-based practice that includes anything necessary. This is a whatever it takes approach. And my understanding is that in California, when wraparound initially started, it truly was a whatever it takes methodology. But then there were issues and concerns about how you would build to meet those needs. That is where we then transformed wraparound into more of a billing system. Like instead of a whatever it takes model, it became whatever we could bill model. And then from that, we are then creating high fidelity wraparound, which includes Medi-Cal billable services that then allows you to pull down funding, and it allows for a whatever necessary model, so whatever it takes. So it's supposed to hit both outcomes. High fidelity means participation requires adherence to nationally recognized fidelity standards, formal provider certification, including county certification, ongoing fidelity monitoring by the Center of Excellence, which is going to be UC Davis, and then representing a significant operation and financial investment. So there's new dollars coming into the system, and making sure that those new dollars have that streamline effect and that every county is meeting the fidelity standards. How it's going to work is that you got to get certified. Certification is now open, and it's been happening with the help of UC Davis. And so CDSS has funded UC Davis currently to help with the high fidelity wraparound certification process. If you go on the UC Davis website on high fidelity wrap, you can find who's been certified thus far at the bottom of their webpage. And I will say this is an ongoing process. So although July 1st was the implementation timeline for bringing high fidelity wrap into FSPs and aftercare, that's still technically in process. And CDSS has said, as long as the provider has shown that they are working towards implementation and certification, then you can contract with them to be a high fidelity wrap provider. And yes, we will be sending this out in the follow-up email, PowerPoint. And then why this context all matters is that providers face a growing expectation to align with high fidelity wraparound. And there's still a lot of questions around how funding and policy is going to work, and using that funding and policy direction to make informed strategic decisions on whether to get involved as a provider, whether you want to hold off or when, and just making sure that the aligned goal is met through implementation, and that implementation is really key here on making this whole vision work. Does the tiered rate structure and high fidelity wrap operate only on a moderate to severe level? No. This is mostly for those with specialty mental health. Residential care and immediate needs. So once you are in child welfare, our understanding is that you essentially, especially if you're in residential care, you are automatically receiving severe mental health services in residential care. Because residential providers, which we call STRTPs, short-term residential therapeutic programs here in California, they must contract with counties to provide behavioral health services. Therefore, they are SMI contracted providers. And if a child is in residential care, they're getting SMI level of care. And I hope audio is now coming back in a better space. All right. And thank you, Steve, for dropping the high fidelity wraparound certification information. All right, next slide. So what's wraparound immediate needs then? So this is, again, a child welfare funded program. It lives under the tiered rate structure. The tiered rate structure dictates how providers offering the service to foster youth and families are paid, essentially. There is a component under that tiered rate structure that is specific to immediate needs funding. So immediate needs is essentially the wraparound immediate needs program. So immediate needs dollars, at first, they were not necessarily attached to wraparound. Now the state has pivoted to say they want those immediate needs dollars to be wraparound dollars, which means that whatever service is provided, you must first get high fidelity wrap certified, and then you can then do additional criteria that relate to child welfare in order to be a wraparound immediate needs providers. The idea here is that every child in Medi-Cal 0 to 21, I believe, has access to high fidelity wraparound if clinically appropriate. And those in child welfare, because of their high behavioral health needs, are gonna have access to wraparound immediate needs. But it builds off of high fidelity wraparound. And again, the idea is that anyone in tiers 2 to 3 plus will have access to those funds. When we come to implementation, there's still so many questions that we're working through with the state. So there's still not clarification on like 2 certification pathways versus 1. Seems like it will be a 2 certification pathway here in California, but there's still a lot of information that we're working through. And just today, we are responding to the wraparound immediate needs concept paper that CDSS released. And we're making sure that DHCS and CDSS are working in tandem, because whatever happens in high fidelity wraparound should be closely tied to what happens in wraparound immediate needs. Next slide. So in the next slide, you hear me talking about the TRS rates, the tiered rate structure. This is what I'm talking about. The tiered rate structure, so in high fidelity wraparound, in order to assess whether high fidelity wrap is needed, there's a CANS assessment that must be done. That also aligns with what happens when a child is placed in child welfare. You're supposed to do this CANS assessment that's already in place today. And depending on the level of needs of that child, they'll be placed in one of these tiers. Tier 1 is lowest needs. Tier 3 plus is the highest need kiddos. You could see that funding essentially increases. Mine is between tier 2 and 3 for the admin rate between all of these tiers. There's a lot more money for care and supervision, means that more money going to families and caregivers. Now, strength building dollars is a new dollar stream that's going to be given directly to youth to use however they would like. They have full autonomy. Then there's the immediate needs funding, which only applies to those kiddos in tiers 2 to 3 plus. And these are the funds that I'm saying will be used from Medi-Cal match to help counties implement high fidelity wraparound. So you could see that the immediate needs funding increases per tier with nothing for tier 1. All right, I'm going to start speeding this up because I'm noticing I'm almost out of time and I'm not even halfway through. All right, next slide. And if we go one more. So on this slide, we're just really showing what the state has shared with us. It will be for high fidelity wraparound, there will be a bundled rate. What is included in that bundled rate is kind of in this green box. So it's targeted case management, including things like peer support services, psychosocial rehabilitation, crisis interventions. There is a certain high fidelity wrap team that you must stack up. We have learned from the state that they will allow you to have one team member have multiple roles, especially in smaller counties, but they suggest that there will be one role per staff. That's the best way to implement it, but because of workforce shortages, they understand that that may not be possible in all regions of California. They will allow for additional behavioral health specialty billing if it's things that fall outside of the bundled rate. This is still in concept. We have provided comments to draft concept papers, but nothing has been finalized. Next slide. There's also going to be a bundled rate. The bundled rate is somewhere between 5,000 and 7,000, with median being around 6,000. So this is the money that the county is going to receive to implement high fidelity wraparound. What the county then negotiates with the provider and the pass-through rate, that will look different. We've heard from some of our providers that the pass-through rate sometimes is as low as like 40% and as high as around 65 to 75%. DHCS, like I mentioned, will not set the case ratios for counties or providers, but there is guidance on what that should look like. And so some of that information is here. Next slide. And then we'll talk through in future slides what the staffing looks like. So where are we with implementation? I mentioned that July 1st of this year was the implementation for DHCS to establish high fidelity wrap reimbursement for behavioral health plans to provide high fidelity wrap through the BHSA Full Services Partnership, FSP, along with aftercare services, which lives a little bit more in the child welfare space. However, CMS has not yet approved the California State Plan Amendment, so the SPA, that would establish the Medicaid reimbursement methodology and the bundled rates that we just shared. So that is still pending approval. And so with July 1st deadline implementation, what we've heard is that CDSS is allowing counties to move forward with high fidelity wraparound, but to use your regular specialty mental health billing system and your codes to be able to continue to bill for services until this bundled rate is approved by CMS. That is what we last heard. We just recently got word that that may have shifted and changed, so we're trying to get clarification from DHCS on that. So counties should be preparing by developing the high fidelity wrap contracting strategies, the RFPs, identifying their provider network, planning for reimbursement under specialty mental health, and then coordinating referrals and how all of that is going to look like within the county system. And then providers should become high fidelity wrap certified, should start moving towards those goals, and engage with behavioral health plans to pursue high fidelity wrap contracting opportunities. So key takeaways, even as the state awaits that federal approval from CMS on the rates, they are saying that counties should be moving forward with developing the contracting opportunities, the RFPs, the high fidelity wrap certification for providers in the county themselves, and moving things forward so that when that CMS rates drops, they're ready to implement and move that along. Next slide. All right. So high fidelity wraparound COE. This is a center of excellence. This center of excellence is the one that predominantly will be monitoring fidelity under the high fidelity wraparound program. So what does that mean is that UC Davis has been awarded a contract by DHCS to provide training, technical assistance, fidelity monitoring, and data collection. They are also the ones reviewing your certification application for high fidelity wraparound and approving it. And then counties may submit an engagement initiation form to begin consultations for training. So if you are a county looking to, put in your high fidelity wraparound certification plan, get that approved, there is ability to ask for additional support from UCD so long as you've had the portal registration done and you could show that you are moving towards certification and getting those items squared away for your county. Next slide. So how high fidelity wrap intersects with other behavioral health initiatives. So for BHSA, as I mentioned, it's part of the 3-year BHSA plan that the behavioral health commissions review, and includes FSB programs to be high fidelity wraparound as of this July. So there should have been language that you reviewed in those contracts that pertains to this. High fidelity wrap county contracting, those RFPs are coming down the pike, making sure that they're not excluding child welfare by adding more requirements that pertain more so to behavioral health than child welfare, so precluding them from entering the provider network. And then BH Connect clarified the high fidelity wrap is an EPSDT Medi-Cal benefit. And so that's how it kind of ties into that space as well. Next slide. The next slide just shows the timeline for implementation.
Just want to stop you for a moment. On the slide, the EPSDT, if you know the acronym, can you tell us?
It's a long acronym. Let me quickly look it up because I don't want to get it wrong. EPSDT. Early and periodic screening, diagnostic, and treatment. So it's pretty much a Medi-Cal benefit that guarantees preventative mental health and healthcare services. So it's like access to.
Thank you.
And so this is the timeline. As you could see, we are in July. We're at implementation, but we're still far from having everything we need to implement. So in the future slides, I'll talk into some of those pieces. So going into the next one, I wanted to talk a little bit about the high fidelity wrap, BHIN, the Behavioral Health Information Notice, and the policy manual that are still in draft form. Final has not been released, but this is what was given to us in the draft form, subject to change. Next slide. So you heard me talk about CANs under the tiered rate structure that applies to child welfare, and the efforts to align what DHCS is doing in behavioral health with what CDSS is doing in child welfare. They're both using the CANs, which is a decision assessment that has decision support criteria that DHCS has now revealed and shared with us that essentially says, because you meet the decision support criteria elements through your CANS assessment, you can now access high fidelity wraparound services. And that same CANS is then used if you come into the child welfare space to then determine what needs you have and place you into the right tier that gives you the financial opportunities to meet those needs. So the decision support criteria for behavioral health plans, it must ensure that for all youth whom high fidelity wrap will be claimed have received this assessment. It has to be a uniform decision support tool. So no matter if you're in Riverside, LA, Sacramento, you all are using it. So if the child is moving in between counties, that CANS assessment shouldn't have to be redone. It just can be shared through the third-party administrator, the TPA. And so DHCS and CDSS will continue to work on evaluating how Medi-Cal and high fidelity wrap decision support criteria intersects with CDSS and the tiered rate structure. There's some updates that needs to be done on the CDSS side since DHCS just released this like a month-ish ago, I think. The decision support criteria is research-based. It's a process intended to support clinical decision-making. And again, the clinical piece is very important because it's a clinical decision on whether or not you get to receive high fidelity wraparound. I will say that that decision support criteria will inform the clinician's individualized discretion. But if a child is seen that they need or the family will need high fidelity wrap services to prevent them from going into child welfare, that can be a reason to provide high fidelity wraparound, even if the CANS assessment is not showing a high score to then say yes to high fidelity wraparound. So it's supposed to be like a broader decision space. Next slide. So in this slide, I just wanted to show who is able to make that clinical decision. So it's a physician, licensed or waivered psychologist, social worker, marriage and family therapist, registered professional clinical counselor, a registered nurse. Those are the folks that can do this assessment and say, yes, clinically, we are attestating that this child and family needs high fidelity wraparound. Next slide. So evidence-based services criteria for high fidelity wraparound. So this applies to those who are 6 and older. There's still no real decision criteria developed for those 0 to 5. So that is something that we're working with CDSS and DHCS to try to see if we could develop something to assess the needs for those who are younger that may need high fidelity wraparound, either because they're already in child welfare or to prevent them from entering child welfare. For those ages 6 and older, high fidelity wrap eligibility is really determined through the CANS assessment, and the Child and Adolescent Needs and Strengths Assessment is the full acronym of CANS. But you'll hear CANS throughout the network and whenever you hear us talk about high fidelity wraparound physicians. DHCS has produced those decision support criteria. It applies to both Medi-Cal high fidelity wraparound and Behavioral Health Services Act full services partnership. So again, if you are having to do high fidelity wraparound, you are then using the support criteria. Clinical judgment remains an important component of eligibility, but it's not a limited circumstance. So as I already mentioned, there's other opportunities to be able to enter into high fidelity wraparound services. If it's not necessarily shown through CANS in the most clear way, if the provider feels it's clinically appropriate to offer it to the family, they can do so long as they can state the why. Next slide. So in the next 2 slides, I'm going to go through what is the high fidelity wrap team structure. So there's a facilitator who is really responsible around care coordination and a central guide for high fidelity wrap processes. They facilitate the development of the individualized plan of care. They are supposed to really reflect the family's voice, the cultural strength and needs, and kind of facilitate the CFT space, the child and family team, that then is supposed to meet together. And this includes the child, the family, any kind of adult mentors, providers, therapists, all coming together to really see what are the needs of this child and family, to then ensure that those needs are met and then create a care plan for those needs. So the facilitator is essentially making sure that those things are happening. Then there's a caregiver, parent, peer partner. This is a peer-to-peer relationship, making sure that the parents' needs and the caregivers are validated and heard throughout the CFT process and the care planning and the final care plan that is produced through these CFT meetings. A family specialist, which is the family's primary behavioral health support partner, working in coordination with the youth therapist and CFT. This is more like maybe like the family specialist is supposed to help remove any stigma by helping to explain behavioral health care to the family, making sure that they're getting warm referrals into community services if need be, things of that nature, that those referrals actually came to fruition. And then the youth peer partner is supposed to do similar as a caregiver peer partner, but for the youth themselves. So this one is a little bit more harder to implement because there isn't a career ladder or established youth peer partner career. So it's harder for us to really find this role to then implement to high fidelity wrap teams, but we do believe it is an important piece of the high fidelity wrap team. Next slide. Then there's the supervisor that follows high fidelity wrap processes with fidelities. The supervisor is supposed to really look at what they're doing in the high fidelity wrap space and making sure that the fidelity requirements are being met and that proper hiring, onboarding, continuous quality improvement is occurring, that the training is being done by the appropriate staff and all that jazz. So it's more of that admin coordination, if you will. Then you have the clinician that really provides that clinical consultation. And then you have a fidelity coach, which is a team member that really looks at the CEO, so the center of excellence. So are we meeting fidelity and working with that supervisor on that? But also deepening the understanding of staff on how to implement high fidelity wraparound and what that means for the organization, for the counties that they're working with, etc. Next slide. So referrals are also being coordinated by the high fidelity wrap team. So high fidelity teams coordinate referrals and linkages to services in the community. So a lot of this TCM care coordination work would happen with the high fidelity wrap team. The community developer is expected to build and maintain these referral networks. So there is a community developer that is really meant, and their sole role is to help move the family into community resources whenever the care plan says that's what they need, and being able to do that warm referral that we're speaking of. Some folks in the development of this high fidelity team structure said that wouldn't be needed because they feel like it can be encompassed by others on the team. But DHCS felt like having a specific role just to do that community triaging and making sure those referrals are actually happening and that it's a warm referral and not just a cold call that the family has to make, that those supports are given by the high fidelity wrap team to families. And then referrals can include Medi-Cal services, emergency services, housing and shelter systems, schools and tutoring, regional centers, and things of that nature. Next slide. So treatment intensity and duration. So the high fidelity wrap team must provide at least one contact or encounter per month in order for them to receive the rate. Youth may receive more frequent contacts based on need and their care plan. Contact frequency may vary because some families may not need as much care and attention as others. And the Center of Excellence will monitor all of this on how high fidelity wrap is being delivered to fidelity and whether outcomes are being met and things of that nature. Telehealth can be used to increase access to high fidelity wrap. However, in-person contact between member and their high fidelity wrap team is essential in this evidence-based model. And so the state is really pushing for in-person contacts whenever possible. Next slide. And then you saw me mention that the supervisor is really responsible within the high fidelity wrap team on the team's training. And so the team is required to be completely trained. There's different ways in which you can accomplish this goal. You could do it via the UCD trainings. You could do it separately from that by creating your own training curriculum that then gets approved through your certification process or hiring a third party to do the trainings for you. Staff may begin delivering high fidelity wrap before training because, again, as long as you have your high fidelity wrap plan certified, you can move forward with being a provider while still doing the training pieces because a lot of those training pieces are still being developed by UCD and DHCS. After completing the foundational curriculum, practitioners must complete 20 hours of continued education to maintain that status. Staff do not have to complete the trainings if staff do not complete the trainings on time, and this is us thinking more in the future, not today, because today a lot of these folks are still moving through the training process. But once we are, a year or 2 years into high fidelity wrap, the expectation is that every staff complete the trainings on time. And if they do not, then the supervisor And the High Fidelity Wrap Center of Excellence will essentially tell that program, get it together. And if not, you must replace that particular role on your team to another staff that is trained. And then providers may request approval to use your own High Fidelity Wrap curriculum, as I mentioned, so long as it aligns with the Center of Excellence requirements. Next slide. So now I'll go through this section really quickly because this is around the state plan amendment that requires CMS approval to then move forward with the bundled rate. Next slide. So purpose of this law is for that bundled rate and for CMS to do that federal match for the Medi-Cal specialty mental health system for High Fidelity Wrap-Around. So it moves High Fidelity Wrap toward a bundling monthly rate, establish a county-based rate intended for labor cost and includes inflation, looks at provider rates in California, and then uses a 75% mark to then say this how much you should be giving to your providers. Effective date of this SPA is July of this year, so it's a retroactive approval. Once it's approved, hopefully by CMS. Nothing's been posted yet because approvals have not yet happened. So next slide. What is defined as the bundled rate within the SPA? It includes things like targeted case management, peer supports, like I mentioned, crisis interventions. Draft guidance from DHCS indicates that additional medically necessary services may be arranged, but we need to make sure it's not duplicative of what is offered in the monthly rate. And there are concerns around targeted case management, TCM lockout, which means that if you are a High Fidelity Wrap provider and you have staff that you work with that are not necessarily part of that High Fidelity Wrap team, they may be precluded from billing TCM because you have a High Fidelity Wrap monthly bundled rate. We don't feel that that's adequate. We're calling that the TCM lockout. And so we're trying to work with CDSS to raise alarms and have that be changed. Next slide. So core competencies explained in the SPA is that the SPA does have four main things it accomplishes: the county-based monthly bundled rate, creates a full month of service threshold and what that looks like, clarifies that High Fidelity Wrap does not have a partial month rate, and states that services included in the bundled rate cannot be billed separately, aka no double dipping. Any provider delivering these services through the bundled rate will be paid through the bundled rate, and providers delivering separate services outside may bill for those as long as it's not double dipping. And again, we need a lot of clarification on nuances on what can be considered double dipping. Next slide. This is just us highlighting that the SPA must be approved for this bundled rate to move forward, and that there's still clarifications needed about how these SCRTPs, short-term residential therapeutic programs, can involve themselves in High Fidelity Wrap-Around. CMS has essentially said that because short-term residential therapeutic programs are already contracted with specialty mental health services to offer behavioral health, that it would be seen as double dipping or duplicative to also be a High Fidelity Wrap provider. Therefore, they cannot be a High Fidelity Wrap provider. And it has thrown a wrench in the state's vision, specifically CDSS, on how they wanted to integrate High Fidelity Wrap into these residential care settings. Next slide. So what counts as a full month of service? So there's various delivery mechanisms. So you could use ACT, MST, CSC, and they kind of have their own way of meeting this minimum service threshold. So for ACT and MST, services delivered to the same beneficiary at least 6 separate days in a month, and at least 4 of those services must be face-to-face. So again, telehealth is allowed, but they are pushing for face-to-face interactions as much as possible. Under CSC, services delivered to the same beneficiary at least 4 separate days of the month, and at least 3 of those must be face-to-face. High Fidelity Wrap services provided at least 1 separate day during the month. So those are the things that must be accomplished in order for you to meet the thresholds to get the bundled rate. Next slide. This is where I was kind of referencing the rate methodology for wages. So I'll let you guys read that for your reading pleasure, but it essentially defines what that means and what the high fidelity wrap team annual salaries and wages should look like. Next slide. So county contracting really matters here. So just because we have a spot rate does not mean that the provider will have access to payment automatically. There's wrap guidance and notes from the behavioral health plan plans that we need to really negotiate with the counties as a provider in order to get the right payment to be able to offer the services being demanded from the provider through this high fidelity wrap model. And then provider feasibility will depend on county contracting terms. So again, if county contracts are requiring to have a certain amount of specialty mental health care or wraparound experience, it's going to exclude certain child welfare providers. So eliminating that from the RFPs, it's going to be very crucial. And then making sure that family and youth engagement is there, that evening and weekend urgent care is available. Travel and community-based services delivery can be offered. Billing and compliance, TA and all that jazz, also being offered in a way that can help providers enter this space and be able to offer this service. Next slide. So drawing connections from high fidelity wrap into the WIN, and this is where we're going to talk a little bit more around the tiered rate structure. Next slide. So goals of the tiered rate structure is to restructure rates from being based on placement and being based on the individual needs of each child and their caregivers. So the tiered rate structure, TRS, will provide youth and family settings the same level of funding and support in the care and supervision. So if you guys remember the slide where I shared the tiered rate structure and tiers 1, 2, and 3 and the funding for those, the care and supervision rate is what goes to the caregivers for tiers 1, 2, and 3, and those funds are increasing. Strength building dollars are new to the system, and so is immediate needs. And this is based on the child. So the child has the right to access all these funding streams, regardless of the placement type, which we are very excited to support, but do have questions and concerns about the implementation pieces to make sure that the provider network within our child welfare system does not break apart because there's not enough funding for the cost of care. Child and family teams, CFTs, this exists already within the child welfare system. They are supposed to help educate the social worker from the county to then say, these are the needs of the youth, and then assess the CANS, which is, again, that CANS assessment that is being used in both high fidelity wrap and within the tiered rate structure to identify what the needs are for a particular youth and family. So they are supposed to work in tandem, and the CFTs are supposed to inform the CANS because the CANS assessment doesn't do a very great job on assessing the physical needs of a child, for example. And so the CFT who have those really good relationships with the family and the youth are supposed to further inform the CANS to make sure that the needs are properly identified and then therefore are able to be met in the care plan that is put together by the CFT. If this isn't done correctly, then the needs of the youth are not properly identified and therefore not being properly met. And we need to make sure that dollars are flowing to them. So if the family doesn't want high fidelity wrap, which they do not have to accept, then they should still have access to these dollars under the immediate needs program. And identifying what that means and how they get access to those dollars is where we're having conversations with CDSS today. And without foster family agencies that help recruit resource families, so these are foster families, or help with reunification, and the counties really depend to do 24/7 care because they can't offer that because they don't have the county bandwidth within their staff to do this. It's very crucial that we don't see these organizations close because the tiered rate structure isn't adequately paying for the cost of care. And this is particularly true for residential care because under the residential space, which is tier 3 plus funding, We are seeing funds go down for residential care from current rates today by about $5,000 per child per month, which will lead to a lot of these residential placements to close. And we've already seen 15 closures from 2025 to today, in part because they see no light at the end of the tunnel pertaining to rates increasing, and a lot of them already operating under the red against margins of what they're actually funded. Next slide. So I talked about the CANS assessment. CANS assessment, again, very important because this is how the rates are really being determined by the needs of youth. So if the youth is assessed to be tier 1, but their true needs are putting them in tier 3, we need to make sure the CANS assessment and CFT are functioning to fidelity so that they're working correctly to then make sure that their needs are adequately displayed and accurately met. Next slide. I shared this slide already, but I'm sharing it from another perspective, which is if you look at the administrative rate, that is what foster family agencies get under tiers 1, 2, 3, and 3+. And for SCRTP specifically, because they're residential care, they get both the care and supervision and the administrative rate under tier 3+. However, the rates are $5,000 less than they are today per youth per month, which means that in order to get to the rates we have today, which is about 18,000, it's going to take us 11 years using COLA to get to the rates that we have today. We're going to lose a lot of providers in that care continuum if we have to wait 11 years to get to today's rates, which is already putting a lot of these agencies and residential care to operate close to margins, if not underneath margins, and having to use agency funding, philanthropic dollars, and other things to make up the difference between what the rate is and the actual high acuity needs of foster youth needing residential care today. Next slide.
Oh, and I wanted to just do a time check for you. We will have the recording posted on our materials page for everybody. So I know some people will need to drop off in just a few minutes, and it looks like Liz may have a little bit more information going past past 1 o'clock. So just wanted to let you know that we will go ahead and keep recording and share that later.
Thank you, Teresa, and apologies for not keeping myself in time. I
That's
just wanted to share so much
good information. Yeah, thank you.
And if folks do have questions, I've been reviewing the chat. It's open up in my screen. Just drop it in there. This is a looking at visual from CDSS on how immediate needs programs are supposed to build on the foundation of high fidelity wraparound. So there is a third-party administrator, a TPA. There's a RFI, request for information, out there, and we've heard that they picked who the TPA is going to be. And this is really going to be key to helping to create care coordination between behavioral health and child welfare. And the TPA is going to be responsible for helping with that care coordination and the funding streams. So TPA will help with information sharing, hopefully, will help ensure that braided funding is occurring, and will help ensure that funding is being pulled appropriately from the right funding bucket, depending on what the need is. So is it a flexible dollar, or can it be billed to Medi-Cal under one of these programs? Is it a regional center of service? Is it something that child welfare should be paying? Is it something behavioral health should be paying? Is it something strength building dollars will be paying for? All of these questions the TPA will help answer for providers and county social workers. Next slide. So for the tiered rate structure, CDSS this past January released what they call the cost analyses. This cost analysis was required under AB 161, which is a bill that passed saying, hey, CDSS, we need you to really share your mathematical assumptions as to why you believe the rates you've established under this new tiered rate structure are efficient to cover the cost of care that kiddos need today. So they say it is efficient. They didn't share their mathematical assumptions in detail whatsoever, so that goal was not met. And they really focused their analyses more on the immediate needs program than the full tiered rate structure, which was a concern to us. Next slide. And so some key conclusions in their cost analyses said that the care and supervision and the administrative components are sufficient to cover the cost of the minimum licensing standards for short-term residential therapeutic programs. Minimum licensing standards is essentially the guide that these residential programs and then foster family agencies, they have their own guide that they use for compliance. They must meet that guide to the T. If not, they're out of compliance and they could essentially lose their license. We disagree that the care and supervision and administrative components for Tier 3 Plus is efficient to cover the cost of care. Like I said already, it's about $5,000 less now that we have an increased COLA that went into effect July of this year, given that the budget was passed. So we have extreme high concerns about these residential programs continuing to exist because the funding is a lot lower than it exists today. And then we also have concerns about generally the tiered rate structure really covering the care of the cost of care, because we have reduced the number of children in child welfare, which is amazing. And there's a lot of great work happening, including within the California Alliance, to ensure that we prevent families from entering child welfare, especially if it's because of poverty, and instead connect them to services to prevent them from entering the system at all. So we've done a great job in lowering those numbers. However, those that are in child welfare have higher acuity needs. They may have been sexually trafficked. They may have sexually offended somebody else because someone sexually offended them. And placing those kiddos is very difficult because you cannot place them in houses or homes where there's other kids because of that criminal background that they carry. And they need to redefine what love is to them. And then there's a lot of supervision and oversight that has to happen to really help support the growth and the healing of these youth, especially in short-term residential therapeutic programs. And so we are working with the state to think more about how we could support residential care in California and not have it kind of die off because there's just no funding to fund it within this proposed tiered rate structure. Next slide. So we have been working, next slide, sorry. So this is the last section. This is us talking about some advocacy efforts. We have been working in close partnership with the California Behavioral Health Directors Association, CBHDA, also with the California Welfare Directors Association on the child welfare space, CWDA, and then probation, which is CPOC. And so we've worked together and we share a lot of these priorities. We want to increase the rate within the TRS, the tiered rate structure, to reduce reliance on the wraparound immediate needs funds. Because rates will decrease about a little bit over 5,000, because there's money going to immediate needs that wouldn't be accessed by all providers. We're asking that for those kiddos in residential care, that funding be provided through the care and supervision rate so that they don't have to rely on the WIN funds in order to continue existing. And I linked CBHDA's comment letter that kind of indicates and talks a little bit about that. And they've indicated that they want more of the immediate needs funding to go towards SDRTPs and flex dollars versus the Medi-Cal match for high fidelity wraparound. Ensure that there will be allowance for an assessment in addition to CANS, because like I mentioned, CANS really assesses one piece of the need, which is more on the behavioral health side. How do we make sure that the physical needs and other needs that that child also has are being looked and considered through the child and family team? And they may recommend using other assessments that the state has already developed to then better assess those needs, and making sure that that is allowed is going to be crucial. And then I mentioned the third-party administrator and really wanting to use that TPA to offer TA and training, to support braided funding, To support information sharing, today there's some providers that don't have, many providers actually, that don't even access the cancer assessment that the county does because that information is never shared with them. So therefore they can't talk about it in the child and family team meetings because they don't have the information to go off by. So having that all coordinated and that fidelity piece added is going to be crucial. Next slide. This next slide represents a survey that we did with our providers that are interested in doing high fidelity wrap-around immediate needs, and just overall transition into the tiered rate structure. And so findings show that a lot of some of our foster family agencies don't have Medi-Cal today. And so it's going to be very hard to be a high fidelity wrap provider because you've got to start from ground zero. You got to become Medi-Cal certified to then meet high fidelity wrap requirements for certification, and then continue up to the wraparound immediate needs program. FFAs serve high needs youth, and so many of them are serving what we call ISFC. ISFC, I'm forgetting exactly what it stands for, but essentially it is for youth with the most intensive servicing for foster care. I think it's intensive services for foster care is what the acronym is.
Thank you. I wanted to mention FFA is Foster Family Agency. Is that right?
Okay. Correct. Sorry.
That's okay.
But yes, they are foster family agencies. And so many of them serve these high intense services for foster care youth. That is being eliminated under the tiered rate structure because the state is seeing that those needs are going to be met maybe through high fidelity wraparound or a combination of high fidelity wrap. And then that those youth will be placed in tier 3+, which is the highest need tiers that has the most funding. We don't know whether or not that's going to be true. And so there's a lot of fears from FFAs that are working with these families that they're going to have to cease operations because they won't be able to afford to do it under this new tiered rate structure. County contracting is a central barrier, like I mentioned. A lot of these foster family agencies, some of them have some sites engaged in behavioral health and specialty mental health contracting, but not all of them. And so they're going to need a lot of TA and training to get those Medi-Cal certifications to then move up through the high fidelity wrap certification portal and then win. So I'll let you read the rest for your reading pleasure, but just the key takeaway here is that this is a really big ask of our child welfare providers. And there's a lot of things that they have to get squared away before they can transition to meeting the needs of high fidelity wrap and win and be a provider in that space. And another key takeaway is that, again, it is so crucial that these county contracts for high fidelity wraparound are not excluding child welfare, because child welfare is bringing a unique perspective to those in foster care that will be needed and crucial for the wraparound immediate needs program to be successful. And if counties are going to be dependent on their high fidelity wrap provider network to then meet the wraparound immediate needs that is specific to child welfare, then we believe high fidelity wrap provider networks should include child welfare providers from the get-go. All right, next slide. And so here I just highlight some of our advocacy efforts. We have think tank discussions with CDSS focused on these 5 categories. I will say they've somewhat ceased at this point because we've moved to having larger group discussions with other partners. I've highlighted some of the legislative engagement with hearings that have happened so that if you want to see the recording, you can. And then I also linked our comment letters in case you're interested in looking at that. Last thing I'll highlight is what we're calling the triple threat data strategy. This is where, again, kind of full circle, you all are so crucial to, and if we go on one more slide, Teresa, you all are so crucial in our data development by responding to the Behavioral Health Planning Council Data Notebook Survey, because we will be using that survey data to really put out the next data notebook. We've already been working on cost tables. We worked in partnership with USC, who did a research project for us that really looked and did quantitative assessments by calling and doing phone interviews with foster family agencies and short-term residential therapeutic programs to see how the tiered rate structure, the wraparound and media needs program implementation would be impacting them. So that data will be included hopefully in the final data notebook that the Behavioral Health Planning Council is developing and that you all help to feed into via the survey that will be coming out to y'all very soon. So this all collectively is going to be synergetically coming together in this full data notebook. And then there will be hopefully a webinar early next year that we'll be able to offer under the Behavioral Health Planning Council to help kind of create the full story, if you will, with all the data pieces incorporated. And with that, I apologize for going over, but thank you so much for your attention and happy to take any questions if you have them now, or you feel free to hit me up via email and I'm happy to respond to them that way as well.
Thank you so much, Liz. Really appreciate all the information. Are there any questions right now? Patricia.
I'm sorry. Thank you, Elizabeth. Thank you, Teresa. I recently attended Napa County's quality improvement committee meeting, and there were we were right on target, but for youth second appointments, we made it for this year, but the standards are going up next year, and we're not in line to make it for next year, the state requirements, because and they pointed to the red tape with foster youth getting a second appointment. They get the first appointment, okay. But then, and I talked to a licensed clinical social worker who had worked for CPS, Child Protective Service, and she said that there is an awful lot of signing off in order to get foster youth to be seen. So I'm just bringing this up as a concern. If it's bothering Napa County's quality making the state statutes, it's going to probably bother other counties as well.
Thanks.
Thank you for bringing that up. And I'll just quickly say that we are also seeing that. And that was actually before joining this call, I joined a UCD call talking about CFD and CANS. And in that call, they themselves also acknowledged that there needs to be, we need to alleviate the administrative burden of having the social worker sign everything off so that they can get access to appointments a lot more quickly. And so thinking about how CARES, which is going to be the new CMS CalSAWS data collection for counties, will be used to help with coordinating and creating those streamlined automated approvals so that things can happen a lot more quickly.
Thanks. Is there anybody else that had a question? All right. Thank you so much, Liz. Really appreciate this presentation. And we will have this all on our website and the recording, so you all can share that. And keep in mind, the data notebook has had some issues in the past. The California Behavioral Health Planning Council's Performance Outcomes Committee just hasn't had a lot of performance outcome data in it. So we keep advocating that there be more questions around that. And I think in future years, there will be. The state has identified areas where the counties will start collecting information on performance outcomes related to the programs. So we look forward to seeing that in the future. But still, the topic is very important for the upcoming data notebook, and hope that you all will complete them. And we will hopefully see those go out. They told me they would be out in July, so hopefully you'll see those come in soon to your counties. All right, everybody, thanks so much for joining us today. And thank you all for serving on or supporting one of California's 59 local behavioral health boards and commissions. Everybody take care. Bye-bye.